Picture this. Robert Mitchell is 71 years old, retired, proud, and still living life on his own terms. Every Saturday morning, he pushes his mower across the front yard while the neighbors wave from their porches. He still drives himself to the grocery store, still remembers every birthday in the family, and every Tuesday afternoon, he meets three old friends at a small diner for coffee, cards, and the kind of laughter that makes a man feel young again. Robert is not perfect. His knees ache when it rains. He moves a little slower than he used to. But he is independent, clear-minded, and comfortable inside the rhythm of his life. Then one morning, his wife Karen says, "Robert, you have been putting off that physical for too long. Just go in and get checked." So he goes. No chest pain, no strange symptoms, no emergency, just a routine appointment. The doctor listens to his heart, checks his blood pressure, asks a few questions, and says, "Everything looks pretty good." Robert smiles, already thinking about lunch. Then the doctor adds one sentence that sounds harmless, but changes everything. "Let's just run a few tests." Those words feel safe, don't they? They sound responsible. They sound like prevention. But 3 months later, Robert is no longer the same man who walked into that office. He is recovering from a procedure he never truly understood, for a condition that may never have touched his life. He is weaker. He is anxious. He has follow-up appointments on the calendar, medications on the counter, and a quiet fear in his chest every time the phone rings with another result. Before that appointment, Robert's life was lawn work, coffee, family, and freedom. After that appointment, his life became scans, specialists, decisions, and complications. And here is what makes this so important. Robert's story is not rare. In medicine, this has a name. It is often called a medical cascade. One routine test finds a small abnormality. That abnormality leads to another test. The next test leads to a specialist. The specialist recommends a procedure. The procedure creates a complication. And suddenly, a person who felt perfectly fine is now living with a medical problem that began not with pain, not with illness, but with the simple phrase, "Let's just check." I am Dr. D. Miller, and welcome to Health with Dr. D. Miller. For nearly 14 years, I have worked with older adults who want to stay strong, independent, and fully present in their own lives. And one lesson has become impossible to ignore. After 65, more testing does not always mean better care. Sometimes it helps, sometimes it saves lives. But sometimes, when there are no symptoms and no clear risk, a test can open a door that is very hard to close. That is why today matters. We are not talking about ignoring your doctor. We are talking about becoming the kind of patient who asks better questions before the cascade begins. Because after 65, the goal is not just to find more problems. The goal is to protect your energy, your independence, your peace of mind, and the life you still love living. Now let's talk about routine PSA prostate testing after 70 in men who are low risk and have no symptoms. And I want you to hear me carefully here, because this is the part many people misunderstand. I am not saying prostate cancer is not serious. I am not saying PSA testing is useless. And I am definitely not saying a man should ignore warning signs from his body. What I am saying is this. After 70, if a man has no urinary symptoms, no strong family history, and no previous prostate concerns, the decision to test should not be automatic. It should be a real conversation, because a PSA test does not simply tell you whether you are healthy or sick. Sometimes it finds a prostate cancer that is biologically very slow, so slow that it may never spread, never cause pain, never affect urination, and never shorten that man's life. Many older men live with these slow-moving cancers without ever being harmed by them. But the moment the number comes back elevated, the emotional weight of that result is powerful. The word cancer enters the room, and suddenly fear begins making decisions before wisdom has a chance to speak. That is when the cascade begins. First, the doctor repeats the blood test. Then comes a referral to a urologist. Then a biopsy, then a diagnosis, then treatment options, radiation, surgery, hormone therapy, active surveillance. Each option sounds medical, logical, and controlled. But behind those words are real human consequences. Urinary leakage, sexual problems, fatigue, hot flashes, muscle loss, anxiety. A man who walked into the office feeling normal may walk out with a disease label that changes how he sees his own body. Let me tell you about Bill Carter, a 74-year-old retired mechanic from Kansas City. Bill was the kind of man who could still fix anything with a wrench, patience, and coffee. He spent weekends in his garage, helped neighbors repair lawn equipment, and took his grandson fishing every summer. He had no pain, no blood in the urine, no trouble urinating, no family history of prostate cancer. At his yearly physical, his doctor ordered a PSA test just to be safe. The number came back slightly high. A biopsy followed. The result showed a low-grade, slow-growing prostate cancer. Bill was scared. His wife was scared. His children said, "Dad, just get it treated," so he chose radiation. Months later, the cancer was controlled. But Bill did not feel like Bill anymore. He was tired in the mornings. He planned errands around bathrooms. He felt older, weaker, and less confident. One afternoon, sitting across from his doctor, he said something I have heard too many times. "I know they say they fixed it, but I felt better before they found it." That sentence should stop every man over 70, because good medicine is not just about finding something. Good medicine is about asking whether finding it will improve your life. If you have symptoms, get checked. If your father or brother had aggressive prostate cancer, talk with your doctor. But if you are over 70, average risk, and symptom-free, ask this before the test. If we find a slow-growing cancer, what would we actually do? Would treatment help me live longer, or could careful monitoring protect my quality of life better? That question can change everything. Now let's move to routine bone density scans, especially when one scan quietly turns into years of medication. And before anyone hears this the wrong way, let me be very clear. Osteoporosis is real. Weak bones are real. Falls in older adults can change a life in 1 second. A broken hip can take away independence faster than almost any lab result ever could. So this is not about ignoring bone health. This is about slowing down before a test result becomes an automatic prescription. A DEXA scan measures bone density. It tells your doctor whether your bones look normal, thinner than expected, or in the range of osteoporosis. That information can be useful. But here is where the problem begins. Many people are told almost immediately, your bone density is low. You need to start medication. And suddenly, a person who walked into the office feeling fine walks out believing their skeleton is fragile, dangerous, and ready to break. The most common medications used in this situation are called bisphosphonates. You may recognize names like Fosamax, Beniva, or Actonel. For the right person, these medications can reduce fracture risk. But they are not harmless, and they should not be treated like a vitamin. With long-term use, especially beyond several years, some patients face rare but serious risks, including atypical femur fractures. That means a stress fracture in the thigh bone, one of the strongest bones in the entire body. Some people feel a deep ache in the thigh or groin before it happens. Others do not understand what is going on until the damage is already serious. There is also a rare condition called osteonecrosis of the jaw, where jawbone tissue does not heal the way it should. Again, these problems are not common, but when they happen, they are not small. Let me tell you about Linda Parker, a 72-year-old retired elementary school teacher from Phoenix. Linda was careful with her health. She walked most mornings, cooked simple meals at home, and had never broken a bone in her life. At her yearly checkup, her doctor ordered a DEXA scan. The results showed low bone density for her age. Before Linda had a real conversation about her actual fall risk, muscle strength, balance, vitamin D, calcium intake, home safety, or medication side effects, she was handed a prescription. She took it because she trusted the process. 3 years later, Linda began feeling a deep, strange ache in her thigh. At first, she thought it was just aging. Then the pain became harder to ignore. Imaging showed an early stress reaction in her femur. I still remember what she said. "I started taking this because I was afraid of breaking a bone. Now I'm afraid the medication may be hurting the bone I was trying to protect." That is the conversation we need to have before the prescription, not after the fear begins. Because for many older adults, the biggest fracture danger is not only low bone density. It is falling, a loose rug. Poor lighting, dizziness from medication, weak legs, bad balance, rushing to the bathroom at night. These are the real-world moments where bones break. So before starting long-term bone medication, ask your doctor, what is my actual fracture risk based on my full life, not just this scan? Then ask, can we compare medication with balance training, strength exercises, home safety changes, and fall prevention? That question is not disrespectful. It is wise. Because the goal is not just stronger numbers on a scan. The goal is keep you standing, walking, independent, and unafraid inside your own home. Now let's talk about routine cardiac stress testing in people who have no symptoms. And I understand why this one feels confusing, because on the surface, it sounds like the most responsible thing in the world. Your doctor looks at you and says, you are getting older. Let's just make sure your heart is okay. Who would not want that? The heart is the engine of the body. It is the one organ people fear losing control of more than almost anything else. So when a test is presented as a way to prevent a heart attack before it happens, most people say yes before they even understand what the test can lead to. Cardiac stress test usually means walking on a treadmill while your heart is monitored, or receiving a medication that makes your heart work harder while doctors watch how it responds. If you have chest pain, pressure in the chest, shortness of breath during activity, fainting, unexplained dizziness, or symptoms that appear when you exert yourself, this test can be very important. In the right person, at the right time, it can absolutely guide life-saving care. But that is not the situation I want you to think about today. I am talking about someone over 65 who feels fine, no chest pain, no new shortness of breath, no dizziness while walking, no warning signs. Just a routine stress test ordered because of age, habit, or the phrase, let's just check. Here is where the danger begins. In people without symptoms, stress tests can sometimes produce false positives. That means the test may suggest a problem even when the heart is not truly in danger. But once the result looks abnormal, the medical system rarely stops and says, maybe this is nothing. Instead, the next step often begins. A referral to a cardiologist, a cardiac catheterization, a thin tube placed through a blood vessel in the wrist or groin and guided toward the heart. Sometimes this procedure is necessary, sometimes it saves lives, but it is still an invasive procedure. It can cause bleeding, damage to blood vessels, rhythm problems, kidney strain from contrast dye, and in rare cases, serious complications. Then, if a partial blockage is found, another decision appears. Should we place a stent? Now hear me clearly. Stents can be life-saving during a heart attack. But in stable patients without symptoms, a stent does not always mean longer life or fewer heart attacks compared with strong medical therapy and lifestyle changes. That is the part many patients never hear before the cascade begins. Let me tell you about Carl Henderson, a 68-year-old retired firefighter from Columbus, Ohio. Carl still walked his dog every morning. He got a little winded on steep hills, but he had no chest pain, no pressure, no fainting, and no frightening symptoms. At a routine appointment, his doctor said, let's do a stress test just to be safe. The result looked slightly abnormal. Carl was sent to a cardiologist. Then came the catheterization. Then came the finding of a moderate blockage. Then came the stent. Afterward, Carl was placed on blood thinners. He bruised easily. He worried when he shaved. He worried when limped stairs. He worried every time his heart beat a little faster. Before the test, Carl felt like a strong, older man. After the test, he felt like a heart patient. That emotional shift matters. So before agreeing to a stress test when you feel fine, ask your doctor, what symptom or specific risk are we investigating? Then ask, if this test abnormal, what happens next, and would that next step help me live longer, feel better, or stay independent? Because after 65, the best heart care is often not chasing silent findings. It is controlling blood pressure, improving cholesterol, managing blood sugar, walking daily, sleeping better, building strength, and treating the risks you already know are real. Now let's talk about routine carotid artery ultrasound in people who have no symptoms. And this one is important because it sounds so logical that almost no one questions it. The carotid arteries are the large blood vessels in your neck that carry blood to your brain. So when someone says, let's check those arteries and make sure there is no blockage, it feels like common sense. It sounds careful. It sounds protective. It sounds like the kind of test that could prevent a stroke before it ever happens. But after 65, especially when a person has no symptoms, the story becomes much more complicated. Many older adults have some plaque in their arteries. That does not automatically mean a stroke is about to happen. Some narrowing can stay stable for years. Some plaque never causes a single symptom. But once a test finds narrowing, the medical system often begins moving. First comes worry, then a referral, then another scan, then a specialist, then a conversation about surgery. And that is where the risk becomes very real. The surgery often discussed is called carotid endarterectomy, a procedure where doctors remove plaque from the artery in the neck. In the right patient, especially someone who has already had warning symptoms, it can be important. But in a person with no symptoms, the benefit is often much less clear, and the risk is not imaginary. A procedure meant to prevent a stroke can, in rare cases, trigger the very stroke everyone was trying to avoid. A small piece of plaque can break loose, blood flow can be disturbed. Complications can happen during or after the procedure. Let me tell you about Susan Bennett, a 73-year-old retired nurse from Raleigh, North Carolina. Susan was the kind of woman who did everything right. She took her blood pressure medicine, walked with her neighbor in the mornings, cooked most of her meals at home, and never missed her yearly checkup. One weekend, she went to a community health event where they offered a stroke prevention screening. The phrase alone sounded reassuring. Who would not want to prevent a stroke? The carotid ultrasound showed moderate narrowing on one side. Suddenly, Susan could not sleep. Every headache felt dangerous. Every moment of forgetfulness scared her. She imagined a stroke waiting around the corner. A specialist mentioned surgery as one possible option. But here's the key detail. Susan had never had symptoms. No sudden weakness, no facial drooping, no slurred speech, no temporary vision loss, no episode of confusion that came and went. Nothing. She got a second opinion, and that conversation changed everything. Instead of rushing toward surgery, she focused on the things that truly drive stroke risk: blood pressure, cholesterol, blood sugar, heart rhythm, activity, and medication consistency. That is the point I want you to feel. If you have symptoms, do not wait. Sudden weakness, trouble speaking, facial drooping, vision loss, or confusion should be treated urgently. But if you are symptom-free, ask before routine screening, do I have a medical reason for this test? Then ask, if this scan finds narrowing, would treatment make me safer than careful medical management? Because after 65, the goal is not to find every silent imperfection. The goal is to prevent real harm, protect your brain, and avoid turning a quiet finding into a life-changing procedure. Now we come to the checkup that almost most nobody wants to question, routine colonoscopy after 75 in low-risk adults. And I understand why this one feels uncomfortable, because for decades, colonoscopy has been presented as one of the strongest tools we have for preventing colon cancer. In many adults, especially earlier in life, that is absolutely true. Finding and removing precancerous polyps can save lives. So please do not hear this as an attack on colonoscopy. That is not what I am saying. What I am saying is this. After 75, especially in people with no symptoms, no family history, and clean previous colonoscopies, the risk-to-benefit math begins to change. And that change is something every older adult deserves to understand before automatically saying yes. A colonoscopy is not just a quick look inside the colon. It starts days before the procedure. You change your diet. You stop certain foods. You drink bowel prep that forces your body to empty itself again and again. For a younger, stronger adult, that may be unpleasant but manageable. For an older adult, that preparation can become a real physical stress. It can cause dehydration. It can disturb sodium and potassium levels. It can strain the kidneys. It can put pressure on the heart, especially in someone who already takes blood pressure medication, water pills, blood thinners, or has heart rhythm issues. Then comes the procedure itself, with sedation, monitoring, and the small but serious risk of bowel perforation, which means a tear in the colon. In a younger person, that is already serious. In a 78-year-old, it can mean emergency surgery, infection, hospitalization, a colostomy, and a recovery that steals independence almost overnight. Let me tell you about Margaret Wilson, a 78-year-old retired librarian from rural Pennsylvania. Margaret was careful, organized, and proud of how well she had taken care of herself. She had colonoscopies in her 50s and 60s. Both were completely clean, no polyps, no family history of colon cancer, no blood in the stool, no unexplained weight loss, no major change in bowel habits. Then she changed primary care doctors. At her first visit, the new doctor looked at her chart and said, "You are due for another colonoscopy." Margaret paused and asked, "At my age, do I really still need one?" She was told it is routine, and that word, routine, made the decision feel simple, so she agreed. But the prep hit her harder than anyone expected. By the next morning, Margaret was weak, dizzy, confused, and barely able to stand. Her daughter found her sitting on the bathroom floor, frightened and shaking. Instead of driving her to the colonoscopy center, her daughter drove her to the emergency room. Her electrolytes were dangerously off. She was dehydrated. Her heart was under stress. She spent several days in the hospital. And here is the painful part. She never even had the colonoscopy. Later, Margaret said, "I felt healthier before I tried to get that test. That sentence should stay with you." Because screening only makes sense when the benefit is likely to outweigh the harm. If you have symptoms, the story changes completely. Blood in the stool, unexplained anemia, ongoing abdominal pain, sudden changes in bowel habits, or unexplained weight loss should always be evaluated. If you have a strong family history or previous high-risk polyps, that also changes the conversation. But if you are over 75, low risk, symptom-free, and your previous scopes were clean, ask your doctor, what is the expected benefit for me personally? Then ask, are there safer options, like stool-based testing? That makes sense in my situation, because the goal is not to do every test forever. The goal is to choose the care that protects your life, your strength, your dignity, and the years you still want to enjoy. Now let's bring everything together, because what I want you to take from this conversation is not fear. I do not want you walking away afraid of doctors, afraid of tests, or afraid of taking care of your health. That is not the message. The message is wisdom. The message is slowing down long enough to ask whether a routine test is truly helping you, or whether it might open a door you never needed to walk through. After 65, your body deserves care that is thoughtful, personal, and honest, not automatic, not rushed. Not based only on what is written on a checklist, because every medical test has two sides. One side is the possible benefit. A test might find something early. It might reveal a real danger. It might help your doctor protect you. But the other side is the possible harm. A test might find something small, silent, and harmless. It might create fear. It might lead to another scan, then a biopsy, then a specialist, then a procedure, then a complication. And before you know it, the person who walked into the office feeling strong is now living like a patient. That is why I want you to carry these questions with you. Write them down, Put them in your phone. Keep them in your purse, your wallet, or next to your medication list. Bring them to every appointment, especially if you are feeling well and someone recommends a screening test. The first question is, what is the false positive rate of this test in people my age? That question matters because a false alarm can still start a very real cascade. The second question is, if this test finds something, what would we actually do next? Do not let the conversation stop at finding something. Ask what happens after the finding. Would there be another scan, a biopsy, a surgery, a medication, a lifelong label? The third question is, would treating what we find help me live longer, feel better, or stay independent? That is the heart of the matter. You are not trying to win a perfect lab report. You are trying to protect your real life, your mornings, your walks, your family dinners, your ability to move through the world with confidence. The fourth question is, what are the risks of the follow-up procedure or treatment? Every procedure has a risk. Every medication has a trade-off. You deserve to know those risks before you are already halfway down the road. And the fifth question is, what happens if we monitor this instead of treating it immediately? Sometimes watchful waiting is not giving up. Sometimes it is the smartest, safest, most respectful choice for an older body. I want you to think about someone who needs to hear this. Maybe it is your husband. Maybe it is your wife. Maybe it is your father, your mother, your brother, your sister, or the adult child who helps you manage appointments. Send this to them. One conversation before a test can protect years of independence after it. And if this has ever happened to you, if a routine test led somewhere you never expected, leave a comment below. Your story may be the warning someone else needs before they say yes too quickly. I am Dr. D. Miller, and this is Health with Dr. D. Miller. After nearly 14 years of working with older adults, I believe this more than ever. The best healthcare after 65 is not always the most aggressive healthcare. The best care is the care that matches your body, your risks, your values, and the life you still want to live. So before your next test, pause, ask, think, protect your independence. And remember, a longer life is not just about finding more problems. It is about making wiser decisions before new problems are created. This video is for educational purposes only and does not replace personal medical advice. Always speak with your own doctor before starting, stopping, delaying, or changing any test, medication, or treatment plan.